All right, good morning, everybody. We have a fourth-year resident, Alex Lancaster, most of you probably know, giving us a lecture this morning, which I've been looking forward to, on occupational risk for the pregnant orthopedic provider. Alex, whenever you're ready, take it away.
Okay, perfect. Good morning. Like Dr. Tischer was saying, I'm Alex Lancaster, one of the fourth-year residents, and happy to be talking to you guys today on occupational risks for the pregnant orthopedic provider. The topic of this talk, like I stated, is occupational risks. And while I often focus on residents and attendings, much of this can be applied to our PAs, scrub techs, and other female team members. If we're successful in increasing gender diversity in orthopedics, the number of female surgeons will continue to grow. As there is an inherent conflict between training years and childbearing years, the number of pregnant providers will also grow. While not all women will choose to have children, many will, and a better understanding of this topic can help us to support our colleagues and reduce their risks. I'll begin with a literature review regarding common OR concerns in regards to pregnancy, including MMA cement, physical stress, and radiation. I'll then examine the literature on infertility and pregnancy complications in female orthopedists. We'll explore what impact pregnancy bias and concerns may have on gender diversity in our field. And finally, I'll share some of the recommendations that have been made by other authors to potentially address some of these issues. I have no disclosures. This talk will be discussing some potentially sensitive content, including pregnancy complications and miscarriage. I'll start with practical considerations for OR safety, as this information is broadly applicable to all of our teams. I will note that all women must ultimately decide for themselves how they want to handle potential dangers and exposures. I do hope that this information can be used to aid in evidence-based decision-making and risk reduction. The first topic of concern is methylmethacrylate, or MMA.
Metabolized to methylacrylic acid, which is known to be toxic to some human tissues with high levels of exposure. There's been concern about the safety of MMA in pregnant women.
A number of animal studies from the 1970s showed teratogenic effects. These original studies were done due to concern in the dental industry with cement being used for that application. Due to its known general toxicity, the EPA has advised that exposure not exceed 100 parts per million in the air over an 8-hour period. In 2021, a systematic review was published on this topic in the Journal of Arthroplasty. They found 9 total studies that met their inclusion criteria, 5 from the dental world and 4 from the orthopedic literature. I will quickly go through each of these studies to paint a full picture of the available literature. We'll start with the animal studies. 3 animal studies using rat models from the 1970s were identified. The first group injected high levels of MMA, up to 30% of the known lethal dose, intraperitoneally into a group of 15 pregnant rats at multiple points during their gestations. They sacrificed the rats just prior to delivery and performed anatomic dissections. They used this information to find increased abnormalities, increased fetal death, and lower birth weights in the MMA groups compared to controls. The next study exposed 18 pregnant rats to high levels of MMA vapors, 13 times the recommended EPA maximums, for 4 hours daily for almost half the duration of their pregnancies. The rats were similarly sacrificed and examined prior to delivery. They found slightly higher birth weights and no evidence of fetal toxicity or teratologic effects. The last study exposed approximately 50 rats to high levels of MMA vapors, 25 to 75% of the known lethal dose, every day for approximately half of their gestation. They found an increase in early deaths and abnormalities, along with lower birth rates in the MMA group. While the findings from these studies sound really concerning, they consist of relatively small sample sizes in rats and levels of MMA exposure far beyond recommended amounts. Another major limitation is that only one of the two studies with adverse outcomes looked at vapor exposure specifically, which is what we worry about in our field. One basic science study was included in which embryonic neural tissue was directly exposed to MMA continuously for 48 hours. The neurons were examined compared to controls and found to have increased LDH levels indicating cell damage, along with shrunken cell bodies and cell lysis. They concluded that MMA may be neurotoxic. As we all understand, basic science studies don't always directly apply clinically. And once again, while this sounds concerning, I think it's difficult to extrapolate this Petri dish study to humans in the operating room. There were two retrospective studies done that were identified and included in this meta-analysis from the dental field, as dentists also use MMA in their cement. The first compared a group of 558 dental surgeons to a cohort of high school teachers. MMA was not specifically included in this study. They found that in general, the occupational exposures faced by the dentist group did not affect their fertility compared to control. And they are assuming that the majority of these dentists were exposed, but like I said, they did not actually ask the dentist about this exposure. The second study looked at 222 miscarriages and a number of control births in female dentists compared to a group without the same occupational exposures. They found a slight, non-significant increase in miscarriage in those exposed to MMA. However, they noted that they could not control for other chemical exposures, which are common in dentistry. There are two published studies looking at MMA levels in breast milk and serum. It was really interesting reading these because I feel like I've heard them quoted quite a few times. The first study took samples from two lactating arthroplasty surgeons who were exposed to MMA without hoods during 4 cases throughout the day. They compared them to 2 unexposed lactating controls. A total of 25 breast milk samples were analyzed to capture multiple points after cement mixing. Using very sensitive testing equipment, they found no detectable MMA in any of the samples or in any of the blood serum samples, which were also tested for these women. The second study exposed 20 healthy volunteers to MMA in a simulated operating room environment. They did not use hoods and mixed in an open bowl, which would be considered the highest risk setting for MMA exposure in our ORs. Serum samples were taken at 30 seconds and 3 minutes after mixing, as MMA is known to be quite volatile, and it was undetectable in all samples. The last study included is the most recently published and provides the most useful and applicable data to our field. The authors performed a number of simulated studies in an OR environment using vapor monitor probes and gas chromatography. They used this to measure MMA exposure to the surgeon, scrub tech, and circulator. They tested vacuum mixing with and without hoods, the creation of antibiotic beads without hoods, and the simulated spill of the monomer itself onto the drapes. They repeated each of these experiments 4 times. The authors found that the OR levels never reached greater than 21 parts per million, and in their experiments, all MMA levels were negligible after 30 minutes, but in the vast majority, the levels were close to 0 after 20 minutes. Using their results, a surgeon who performed 4 total hips over an 8-hour workday would have a total exposure of 0.15% of the OSHA limit, and a scrub tech in the same scenario, 0.49% of the OSHA limit in a day. They found that the use of a hood reduced exposure for the surgeon, but slightly increased exposure for the scrub tech, likely due to their proximity to the monomer and recirculation of air. Vacuum mixing significantly reduced exposure levels compared to hand mixing, up to 75%. and distance away from the compound was also found to be protective, as in all of their studies, the circulators were shown to have very low levels of exposure. You can see one of the graphs from the continuous data that they pulled from their vapor monitors here on the right chart. You can see the circulator in green at the bottom with almost a flat line, very, very low levels. And the surgeon and scrub tech, both with a spike, but overall returning to low levels very quickly. I took the time to explore this specific literature in depth because it's something that comes up a lot for us and affects our actions and staffing in the OR directly. To this point, this survey study from 2020 asked 250 female orthopedic residents and attendings about their behaviors around MMA. 70% reported using it frequently, and 40% stated that they would leave the OR if pregnant to avoid MMA exposure. Over 20% said that they would leave the OR even if they were the primary surgeon. 25% said they would leave if they were breastfeeding. And 8.4% said that MMA exposure affected their subspecialty choice, which is especially concerning for fields like trauma and arthroplasty, where MMA is often used and the representation of female surgeons is quite low. While adverse effects cannot be excluded based on the available evidence, there is no compelling evidence that MMA levels encountered in the modern OR lead to pregnancy complications or fetal abnormalities. Surgical hoods for the surgeon, a vacuum mixing system, and distance from the compound all significantly reduce exposure. Certain device companies are also now selling all-in-one contained cement mixing systems, like the one pictured here, which further reduces vapor levels. And they're specifically marketing it as something that may be safer for nurses and scrub techs who are pregnant in the operating room. While this is probably unnecessary based on the data, it is one extra added layer of security for those who are nervous about this. The survey study from the prior slide found that MMA-specific education significantly increased the odds that women would stay in the OR while pregnant. Knowledge of the literature hopefully will alleviate the need for female surgeons and staff to feel compelled to leave the operating room during critical portions of the case or to disclose early pregnancies, which is another major source of potential stress. The next hazard we commonly think about is physical stress. Orthopedics is known as a specialty that requires heavy lifting, periods of prolonged standing, and often long work hours. Some studies on pregnant women and the general population have shown an association between these things and decreased intrauterine growth. Other studies have pointed to heavy occupational activities as a risk factor for preterm delivery. However, the evidence on this is varied. There are 2 review articles from our field specifically that explore this topic. Both articles tout the benefits of light exercise for pregnant women, but then express concerns about prolonged standing over 8 hours and long work hours over 40 per week. They cite the previously mentioned studies showing decreased intrauterine growth and increased rates of preterm delivery. They cite one study which showed that long work hours had the same effect on intrauterine growth as smoking. They also mentioned fatigue and dehydration as known risk factors for preterm labor. Overall, these articles are pretty non-committal on this topic, hinting at possible connections, but never offering much else in terms of concrete advice. Interestingly, both articles mention that orthopedic surgeons only exert 20 to 30% of their maximum aerobic capacity during surgery. One of the articles then concludes with the statement that because of this, the risks associated with strenuous activity for pregnant orthopedic surgeons is low. I was curious as to where these specific exertion percentages came from, so I found the original article. This wouldn't be a grand rounds talk unless you pulled up an article from 50 years ago that would never get published today that we're still quoting, and that's this. So in this study from 1975, they looked at 4 surgeons and ran aerobic tests on them to determine their exertion tolerances. They then tracked their heart rates through a number of different operations to determine how hard they were working. You can see on the right an example of a heart rate monitor through a total hip arthroplasty. In total, they recorded data for 27 operations. They found that in most surgeries, they fell within 20 to 30% of their maximal oxygen uptake. Nearly 50 years later, we're still quoting heart rate data from 4 Norwegian men in articles giving advice for safe exertion levels in pregnant women. This systematic review and meta-analysis, published in 2020 in the obstetrics literature, is the largest review to date on this topic in the general working population. This is a difficult topic to study due to a large amount of confounding factors that cannot be controlled for, but they have the advantage here of very large numbers. They combined 80 observational studies from 30 countries with an N of over 800,000 working women. They found that the odds of preterm delivery were significantly increased by lifting over 100 combined kilograms in a day, prolonged standing greater than 4 hours, and heavy physical workloads. Miscarriage odds were similarly increased by lifting, and the odds of low birth weight increased by prolonged standing. Potential mechanisms for these adverse outcomes have been proposed. Heavy lifting and prolonged standing can lead to decreased placental blood flow. Heavy workloads, along with fatigue and stress, increase catecholamine levels and are thought to increase uterine contractility. Together, these mechanisms are believed to reduce fetal growth and lead to preterm delivery and miscarriage. The same group published another systematic review and meta-analysis in 2019, looking at rotating shift work, fixed night shifts, and long work hours. This study was also quite large, with nearly 200,000 pregnant working women included. They found increased odds of adverse outcomes in all categories, including a 38% increase in the odds of miscarriage in those working over 40 hours per week. The proposed mechanism for these ill effects was similar to the previous slide. Stress levels from prolonged work may have an effect on uterine contractility, and abnormal circadian rhythms alter melatonin levels, which are important for a healthy fetus and placenta. In summary, this is a really difficult topic to study, and practical advice for female surgeons is limited. Based on the available data, it is likely that shift work, long hours, prolonged standing, heavy lifting, and stress increase the risk of adverse events to some degree. If possible, these factors should be taken into account when you're making schedules or assigning OR tasks. Dr. Spina is always willing to hold a heavy leg if you need him to. The last practical OR topic is radiation. We are lucky to have had multiple recent talks over the past few years in our department discussing general radiation safety. In regards to pregnancy specifically, there are a few additional important points. The American College of Radiologists and American College of OBGYNs has stated that single exposures to less than 50 milligray are not harmful to a fetus. The ICRP has recommended that exposure over an entire pregnancy be limited to less than 1 milligray, which is far below the single exposure limit of 50 milligray. For reference, the maximum dose recommended for non-pregnant orthopedists is 20 milligray per year. The effects of radiation depend on the age of the fetus and the dose. Adverse events are most severe in weeks 3 to 8 during organogenesis and then decline through the rest of pregnancy. Only somewhere between 25 and 40% of radiation that reaches the maternal abdomen actually penetrates to reach the fetus. Concerns about fetal radiation exposure have led some women to wear multiple layers of lead. This can be cumbersome, especially when operating, and can contribute to fatigue and dehydration, both of which are known risk factors for complications during pregnancy. Standard 0.25 millimeter lead absorbs 96% of all radiation. Double thickness lead, which weighs 1.5 times more that of the standard, absorbs an additional 3%, up to 99% of all radiation. Special maternity lead also exists that is anywhere from 0.5 to 1 millimeters thick and absorbs over 99% of radiation. This lead often has a thicker portion at the abdomen to add extra security. Maternity lead weighs up to 2 times that of standard lead. And given that at worst, 40% of the radiation that makes it to the maternal abdomen then penetrates through, these thicker and heavier lead aprons are a significant physical burden for a 1 to 2% reduction in exposure. This 2012 study from JBJS measured radiation exposure to a surgeon's abdomen under standard 0.25 millimeter lead, doing a variety of procedures. They then accounted for the max 40% that reaches the fetus and determined how many procedures the surgeon could do within the recommended 1 milligray over a pregnancy. Lumbar spine surgeries were found to have very high radiation exposure levels and low pregnancy limits due to the positioning of the C-arm and where the surgeons stand during the case. And they found the pregnancy limit to be around 20 cases. Other surgeries, such as a DHS for hip fracture, had much less radiation exposure and very high pregnancy limits, around 800 cases. I extrapolated this methodology to a previous study on fluoro exposure and DA hip arthroplasty and found that using their logic, the case limit was over 11,000. Obviously, the amount of fluoro used varies case by case and surgeon by surgeon, but this gives a rough estimate of what these recommendation levels and limits really mean. So in regards to radiation, these are the main takeaway points. If a surgeon is in a high exposure practice and feels that they're at high risk, they should consider wearing a dosimeter and keeping track of their exposure as they go. Reducing radiation exposure when able, using well-accepted methods, such as increasing distance from the source, reducing exposure time, protective shielding, and use of robotics and technology for guidance when able, can continue to limit the level of lead for anyone, but especially the orthopedic pregnant provider. Wearing extra lead aprons or thick maternity lead is unlikely to be worth the physical cost of the added weight. Finally, radiation exposure is most dangerous early on in pregnancy, and those attempting to become pregnant should be extra diligent about their lead use. The first half of the talk focused on very specific OR hazards and how to mitigate them. This next section is meant to shed light on some broader issues faced by orthopedic surgeons wishing to become pregnant or those who are pregnant while in training or practice. The timing of surgical training coincides with prime reproductive years for women. It's well accepted that fertility rates dramatically decrease after age 30 and that women over 35 have a higher risk of maternal and fetal health problems. Despite this, many female surgeons choose to delay childbearing due to their careers. This survey study was published in JAMA last year and looked at female surgeons across all specialties. When I read this for the first time before preparing for this talk, I thought the findings were really alarming, and this is one of the motivations I had for looking into this topic more. They created a large survey study tool using surgeon focus groups, prior studies, and a maternal fetal medicine expert to create the best survey possible. The survey was distributed to both male and female surgeons in the United States. Non-childbearing surgeons, aka male surgeons, were asked to answer questions about their non-surgeon partners to act as socio-demographically similar control groups for pregnancy outcomes. They ended up with 850 respondents in the final analysis, with 692 of those being females and 158 being males with non-surgeon partners. Any men who had surgeon partners were excluded. Lots of data came out of the study, but I want to focus on a couple takeaways. First, 42% of female surgeons experienced at least one pregnancy loss, which is more than double the rate reported by the general population for women aged 30 to 40. 75% of those had miscarriages before 20 weeks. 75% of those that had miscarriages before 20 weeks took no time off of work after their miscarriage. Female surgeons were 1.7 times more likely to have major complications such as preeclampsia compared to non-surgeon females, and this remains significant after in multiple gestations. They found that operating more than 12 hours per week during the third trimester and maternal age over 35 were associated with major complications. Female surgeons were more likely to have MSK disorders during pregnancy, more likely to have non-elective cesarean deliveries, more likely to delay childbearing due to training, more likely to use assistive reproductive technology or ART, and more likely to have postpartum depression. Very few surgeons reduced their work schedules during pregnancy. Fortunately, neonatal outcomes were similar between groups. Given these findings, the authors promote changing surgical culture across all surgical fields to legitimize pregnancy and motherhood. They believe that this could reduce the risk of major complications and the need for fertility treatments. The next study was published in JAOS last year and focused on orthopedic surgeons specifically. They sent a survey to multiple women's groups in orthopedics and received 801 responses, making it the largest ever survey for our field specifically. They found that of those with children, 67% intentionally delayed pregnancy because of their careers. The average age at the birth of their first child was 33.6 years old, which is a decade or more older than the general population. 17% used infertility services for their first child, compared to 9% of women in the general population of a similar age. 24% reported pregnancy complications, compared to around 15% of those in the general population. Multi-gestational pregnancies were a significant risk factor for complications, and the chances of having a multi-gestational pregnancy were increased by age and the use of ART. They did not find an increase in complications between those who worked more hours or operated more or were at a later professional stage in their career. Additionally, they found that on average, women operated until 37 weeks and worked in clinic until 38 weeks. A third of respondents in this study who tried to conceive reported miscarriages, a rate over double that of age 30 to 35-year-olds, and 10% higher than that of age 35 to 39-year-olds. Similar to the JAMA article, 95% of women returned to work immediately after miscarriage, and only 8% sought counseling. Only 28% told anyone at their work that this had happened to them. Up to 38% of women in the general population who have miscarriages report some symptoms of PTSD, pointing to the significant psychological impact that this can have. Hamilton et al. Published a survey study in 2012 in JBJS looking at female orthopedists compared to other female surgeons. They found that orthopedists were more likely than other surgeons to work greater than 60 hours per week and spent significantly longer in the OR per week. 30% of all female surgeons in this study had infertility issues. The complication rates for orthopedists were similar to those reported for non-orthopedists, but much higher than the general population. This is especially concerning given that higher education levels and higher socioeconomic status are generally protective against complications. The most common complication was preterm labor, and the risk was increased in residents working over 60 hours per week with an odds ratio of nearly 5. When US population data was controlled for age, race, education, and health status, orthopedic surgeons were still 2.5 times more likely for preterm delivery. They mentioned stress as a likely contributing factor to these discrepancies. Prior prospective studies have shown longer times to conception in those with higher stress-related biomarkers, and that women who perceive their jobs as demanding are less likely to conceive. At this point, we've covered some of the common OR concerns for pregnant providers and the available literature on these topics. We've also looked at some of the concerning data on infertility and complication rates among female surgeons. For the final portion of this talk, I want to discuss some of the broader implications of pregnant surgeons on the field of orthopedics. We're all well aware of the gender disparities that exist in our field. Currently, over 50% of medical students are female, while only 14% of current orthopedic residents are female. There's an even smaller percent of practicing female orthopedists. At Utah, we're currently at 31% female residents. The graph here shows the increase in female representation in different surgical subspecialties from 2005 to 2017. Ortho is shown by the black line along the bottom. The most recent numbers show that we continue to have the lowest proportion of female residents among all specialties. This study from 2021, co-authored by one of our own, used NPI registry data to identify the proportion of active female orthopedists in the United States and the growth in this percentage over the past 8 years. They then used that growth rate to project forward and determine the year at which the representation of women would achieve parity with the proportion of all women physicians, which is currently at 36%, and the proportion of all women in the United States, which is at 51%. They assumed that these proportions would remain static over time for the sake of calculation. They determined that to reach the current level of gender parity for physicians, it would take 217 years, and for the general population, 326 years. So if nothing changes, we're over 200 years from nationally reaching the proportion of female residents that we have at Utah right now. The AAOS has recognized this issue and in 2019 introduced a 5-year strategy to increase diversity within orthopedics, specifically citing gender disparity as a primary target for improvement. They now make a yearly progress report, which is available on their website, where they analyze and report on the 5 subcategories. They're making a concerted effort to change the trajectory that we're on as a field. Most of their updates in the recruitment tab specifically were related to building relationships with orthopedic groups such as the Ruth Jackson Orthopedic Society. Nowhere that I could find was family planning or pregnancy or any of these topics mentioned in their efforts. The topic of gender disparity in ortho has also been a popular area of research, especially in the past 5 to 10 years. There are numerous articles looking at why more women aren't applying to orthopedics and how to address the issue. There are a number of commonly cited barriers for women, including jock culture, perceived physical demand, lack of female mentors and role models, and lack of early exposure to the field. Gender bias and concerns about work-life balance are also commonly discussed, which are certainly intertwined with pregnancy and family planning. This study, published in 2016, looked at 2012-2013 residency match cycle data and surveyed over 10,000 applicants about the prevalence of illegal questions asked to them during their interviews. They found that overall, 65% of applicants reported illegal questions, with that rate being higher up into the 80% for surgical specialties. Women were more likely to be asked questions about their gender, marital status, and plans to have children. In the surgical specialties, women were more likely to be asked about their childbearing plans than their male counterparts. Questions about gender and childbearing were reported to make women feel uncomfortable when they were asked these things at a much higher rate than men. And they also found that being asked these questions about childbearing plans and gender were the most likely to negatively affect how an applicant ranked a program. This study, published in 2019, surveyed 488 female orthopedists specifically about the rates of inappropriate interview questions they encountered over nearly 50 years. They reported that the rates of inappropriate questions had not changed significantly over that duration. They also found that the most common categories of inappropriate questions had to do with raising children during residency, marital status, and pregnancy during residency. Nearly 30% of all applicants were asked about pregnancy specifically. Oftentimes, I think when we look at literature about illegal questions or discuss this, there are some questions that count as illegal that we all see as being pretty benign. Like, is anyone coming to residency with you? Do you have any kids? But I think that this data shows that If someone is specifically asking you about becoming pregnant during residency, it's hard to write those off as harmless questions. It is no secret that bias toward pregnant residents exists, and it's very clear that this is something that applicants get asked about. This 2019 study showed that the vast majority of female residents did not have children and were not pregnant. Nearly half of them had deferred specifically due to residency. 60% reported having had experienced bias against pregnancy during residency from other residents, and 50% reported experiencing bias from attendings. From residents, the major concerns are related to call schedules and work distribution. From attendings, the major concerns that were brought up were about impact on performance and career trajectory. Over 60% were unaware that orthopedic surgeons had increased rates of pregnancy complications compared to the general public. Only 22% reported that their program had a formal maternity leave policy. Nearly half did not know if their program had one or not. This study out of Iowa states that residency applicants often look to program websites for more information about a program. They reviewed 178 ACGME accredited program websites to determine what kind of information was available to those thinking about having families and for family and lactation planning. They found that only 2.8% had a written breastfeeding policy available. Another 20% had links to the general institutional GME websites that somewhere did have a policy written out. Only 1.7% mentioned dedicated lactation facilities. The odds of having a written policy increased with an increasing number of female attendings in the program. While this may seem like a really small thing, they emphasize that ensuring available breastfeeding support for trainees and having stated transparent policies could contribute to an improved perception of childbearing during residency. This final study surveyed orthopedic program directors in 2020. They found that 40% did not think lactating residents should be allowed to scrub out of a case if they needed to pump. 40% said they had no lactation facilities available to residents at their program. 77% thought pregnant residents placed a burden on other residents, compared to 45% who believed that that was true for male residents with children. This brings me to some concluding thoughts from what we've covered so far. In regards to OR safety, cement and radiation exposure are overall low risk for the pregnant provider with the proper protection and monitoring. Physical stress, while hard to study, is likely a much bigger contributor to complications than we give it credit for. If at all possible, we should do our best to minimize unnecessary physical demand and grueling work schedules for those who are pregnant, whether they be residents or other team members. The data on infertility and pregnancy complications in female orthopedists is alarming and cannot be contributed to age alone. Just as we've had prior Grand Round talks on mental health and burnout, I think this is a topic worth discussing to maximize the well-being of those in our field. Medical school and surgical training require women to choose between balancing pregnancy during demanding training years or risking complications and infertility due to advanced maternal age. We should consider what cultural changes we can make to legitimize pregnancy and constructively accommodate it. Pregnancy complications and the need for fertility treatments can have a major impact psychologically on families. The ultimate goal is to minimize risk for ourselves and our colleagues. Addressing bias surrounding pregnancy and supporting pregnancy and breastfeeding during training may also aid in the recruitment of more women to our field. I want to end by sharing a few recommendations made by the JAMA article I discussed previously to address the needs of early career surgeon mothers and mitigate their specific health risks. They end their article with a full page of these. Obviously, some of these may be more difficult than others to implement and may not make sense for an orthopedic department specifically, but I think they bring up some interesting things to think about moving forward. They recommend that policy should exist to support pregnancy and breastfeeding residents and clearly and they should be clearly written and openly discussed. This demonstrates department support and helps to avoid misunderstandings between team members about what is appropriate. Schedule flexibility should be possible to mitigate potential risks to maternal and fetal health from poorly timed heavy workload rotations or night float. Pregnant residents, in their opinion, should not be asked to make up call during other parts of their pregnancy, as it is known that rotating shifts and fatigue and stress can contribute to complications at any point during the pregnancy. Cross coverage for long cases should be available to facilitate pumping, and faculty should be educated if needed on pumping needs and frequency to better understand why a resident or staff member may need to leave a case. Coverage of service duties and call should be provided by moonlighting MDs or incentivized trainees if possible to avoid resentment from colleagues and feelings of guilt from the pregnant resident. Fetal dosimeters should be provided and checked monthly. And residents, whether childbearing or not, should be encouraged to take full parental leave to promote bonding and prevent postpartum depression. Like I said, these are the recommendations specifically from the JAMA article, but I think that they are some interesting things to think about. The ABOS only requires 46 weeks of clinical engagement per year for an orthopedic resident, averaged over 5 years. So this does leave quite a bit of flexibility, theoretically, for scheduling if someone were to need it. Our 6 month of elective chief time here at Utah can also be utilized for making up any rotations that may need to be made up, or for covering cases that may have not been met with case minimums. Although I think given our training program, that's pretty unlikely. So obviously these are difficult topics and there's no one solution for everything. But I think that if we can recognize the problem and meet it with our eyes wide open, we can hopefully make progress in making things a little bit better and safer for our female colleagues. I appreciate everyone's attention and would welcome any questions or comments. Thank you.
I'd like to make a comment. Alex, that was outstanding, truly outstanding, and well overdue for a Grand Rounds presentation. Thank you for all the preparation, tremendous amount of work you put in. There is absolutely no question that we have to pivot as a field, and we have to pivot as people, and we have to pivot as doctors, and we have to pivot in every way. The stress that a woman will feel around this issue in training or not in training, but especially in training, cannot be underestimated. And we got to do better, and we can. And I know Dr. Rothberg's been thinking about this. I think he's going to meet with some folks and try to figure this out better and better. But we talk about burnout. We being the administrators, the people who run hospitals, the people who run educational programs, people who sort of run the thing. We talk about stress and burnout, but we really just talk about it. And I can't imagine greater amount of stress on someone than being told you take call up until the day you deliver. You have to be back at 6 weeks and you're taking call like everybody else. You got to be on the hard rotations, or, you know, that is wrong. That is wrong at every level. And perhaps we have to allow the ABOS, by the way, board of directors did change the rules very intentionally, this 46-week thing, intentionally, so that we could allow residents to have a pregnancy or maybe 2 pregnancies or whatever is needed. But we need to think broadly about how to do this as a field, as a residency, and we need to be compassionate to each other. And it's nice to be compassionate to all your patients, and it's important and it's critical, but it's got to start here within this group. And so I really appreciate you bringing this. I think it's incredibly important. It is absolutely timely. It is, and we need to get in front of it, as you said, and face it straight on. And so thank you for bringing it to us.
Thank you.
Yeah.
It looks like Patrick Michelier's hand is up. I don't know if that's a mistake.
No, it's not. Thank you, Alex. I'm one of the hand fellows. I just want to make a comment in regards to Garth Saltzman, your sentiments and all in regards to your comments on infertility literature. During my training at UC Davis, the UC Regents switched to a self-funded plan, which eliminated infertility coverage. And as far as my research at University of Utah, it's the same. There's zero coverage for any residents for infertility treatments, for drugs, for procedures. And I would offer that as a small avenue for potential change.
Yeah, I think that's a super good point that I wasn't aware of, but something I don't think I knew before was how time intensive doing IVF or something similar is. And talk about needing time off just to have the baby, but let alone do multiple rounds of IVF. Very expensive and requires lots of doctor's appointments from what I read. So just one more barrier, because as women wait longer, the chances of them needing IVF potentially grows and grows. And then it just kind of compounds the difficulty associated with everything. Thanks.
I just want to make one comment too. I'm Elise. I'm the sports fellow. So I have a 1-year-old and I had a kid in residency and I was the first one in my program to do so. So I don't think no one really knew what to do with me. And I think one thing I wanted to really highlight about your talk was that last slide, that JAMA article about the recommendations of having people available like NPs or PAs or somebody that they can add in and help cover for call or extra like cases or anything when somebody's out for pregnancy, because I think that is a really big thing. Like Dr. Saltzman mentioned, you can talk about it and say, yeah, we support this, but ultimately what supports it is actually having somebody to physically help cover call and cases and things when you're out. I think that there's that article that talked about like 40% and 60% of people saying that the call was that pregnant and on maternity leave co-residents were a burden. I think that should be 100%. There's a matter of fact, they are a burden because it's a loss of work of manpower unless you have somebody to fill that space. So like for me, my program was super supportive in the way that they could be, but I still had to front load all of my calls. So I was taking essentially 2 months of call shoved extra into my 4 months while I was pregnant, which isn't anyone's fault. It's just that we didn't have any coverage for that. So I think actually having tangible solutions is super important.
Awesome. Thanks, Elise. Yeah, I agree. And I think that in general, most people would be happy to cover call for someone if they needed it. But doing things like incentivizing other residents to take call shifts with a little bit of money, or having mid-level providers available if it's a service that needs coverage during the day, could make a big shift in changing it from feeling like a burden to feeling like an opportunity for someone to make some extra money or get some other, cover some extra cases. So I think that, yeah, culturally, it's really important to try to think about that.
Any other comments or questions for Alex? Thanks, Alex. That was fantastic.
Thanks.
Okay. Have a great day, everybody.